Okay, so let's try to understand what's happening here. So let's assume that you have this patient who has asthma, severe asthma, was admitted to the intensive care unit, and he was intubated and placed on mechanical ventilation. You're coming on the shift, and the previous fellow told you that this patient is already admitted. We have ABGs, pH 7.37, PCO2 37, and PO2 is 89. Saturation is 95%. So he tells you that everything is fine. Patient is oxygenating and ventilating adequately. So Yusuf, can you take a look on this graphs and tell me what abnormalities you detect and what changes you want to make in a systematic way? We need to understand how we identify the problem and then how we systematically or stepwise approach to this problem.
So the main thing that I'm seeing here, prolonged time constant. At the same time, like like mainly auto peeping, because it's not returning to zero on the flow and the flow curve exactly.
Okay, so yes, you identify the problem, but let's read all the abnormalities that we see. I'm going to freeze it a bit here so we can make the changes that we want. I think I need to do this first and then get. All right. So first, what do you think about this area here?
So here the inspiratory pressure is a little bit high, or the so that can tell me that there is increased airway resistance.
Okay, so this is the airway pressure.
Yeah.
This is exactly the pressure that is required to overcome the first thing the air is going to face, or the ventilator is going to face, which is the airway resistance, tubes and natural airway resistance. And you can see that these are actually up to probably 33, 34. And this is a very high pressure, indicating that, well, we may have a problem with the resistance. So what do you think about the peak inspiratory pressure here?
Yeah, the peak inspiratory pressure is almost like 41. And at the same time, the plateau is 20. So the difference is really high. That can tell me mainly we are dealing with the airway resistant problem.
Okay, so this is the plateau pressure. What do you think about the plateau?
Plateau is fine. I think it's 20.
20, 22, is that something that you would see in normal airways and lungs?
I would say yes.
Remember the, in patients with ARDS, we don't exceed plateau of 30 with a PEEP of 12 or 14.
Yes.
So a pressure of 20, 22 for the plateau is a bit higher than what normally we should have. Of course, you're not seeing the progression of the problem, so you're just encountering that the plateau pressure is at the level of 20, and that's kind of a little bit high pressure actually. And now we come back to it and see. But you already mentioned that the difference between the peak and the plateau pressure is high. So that indicates that the problem is
airway problem, more than
lung
or chest wall.
Excellent. So in addition to that, if you take a look, and you already started with this actually, if you take a look on the expiratory flow, you can see that the peak expiratory flow is kind of low a little bit. You can see it's around 20 liters per minute.
Yes.
And then you can see that the slope is kind of shallow.
Yes.
And it's taken a long time to exhale. And that's what you started with. The time constant is prolonged for this patient. And the time constant for people not aware of what time constant is the resistance multiplied by compliance. And usually we inhale or exhale 2/3 of the air in one time constant. So if we have a time constant of 1 second, we would need to exhale the remaining of the air, we would need 2 to 3 times time constant. So if the time constant is 1 second, that means we would need 3 to 4 seconds for a full expiration to be able to exhale everything that we have inhaled during inspiration. And you can see here that, well, 2/3 of the air is probably here, and this is a time constant. So you really need a long time to be able to exhale all the way. And the last thing that you see here is that you have persistent flow at end of expiration. And what does that mean?
Patient doesn't have enough time for the expiration.
Excellent. The patient does not exhale all the way back to 0. So that means that there's air trapping, right? And if there is air trapping, what happens to the alveolar pressure?
It's going to increase.
The alveolar pressure is increased. And what do you call this?
It's auto-peeping.
Auto-peep. So, and that auto-peep should be in this area here. Okay, and that's why the plateau is elevated. So the plateau will be the pressure above the auto-peep. You don't see the auto-peep here, but you incline from it, from the persistent flow at end of expiration. And then when the next breath comes, the pressure has to be built above that auto-peep. So this would be the auto-peep level here. And the pressure is above that. That would be the normal extending pressure for the alveoli without the beep. Is this clear?
Yes.
Okay. So Marwan, let me ask you. So now we identified what the problem. How can we solve this problem?
Okay. So يعني first of all من الفنتليتر ولا هاي أول شيء بدك sorry
can we stay in English please?
Yes, sorry, I just
that's okay.
So first, of course, we can treat the obstruction in the patient like using inhalers, units, or whatever inhalers with bronchodilators.
Okay, so you have bronchodilators, you have steroids on board, but we need the ventilatory management here.
Okay, so ventilatory management. So patient is auto-peeping. So one thing we can do is increase his expiratory time. And I can see there is like we are not using the whole inspiratory time to give the volume that we need to the patient. So we can increase his respiratory time and add that to the expiratory time.
Okay, tell me what you want to do on the ventilator.
Okay.
remember, this patient's pH is 7.37. The PCO2 is 37, and the PO2 is 89. So okay. Perfect oxygenation and ventilation.
So I want to increase the inspiratory time from 1.7 to maybe 1.2.
You want to decrease the inspiratory time? Okay. So first, let me just, okay. So take a look on here. How are you going to decrease the inspiratory time? What are you going to get rid of?
I'm gonna get rid of the time that the patient spends in the plateau.
Excellent. See that time? So this patient he's on 36%, by the way, here. Okay. And this time is inspiratory time that we're doing nothing in it. Okay. So you can see zero flow, and we're holding the breath inside the chest. Why are we doing this? There's no reason why we're inhaling and putting a plateau in the system. You would do that. First, you can identify the problem by doing this, but the only reason why you would hold the air into the lungs is if you want to improve oxygenation. Here we don't have problems with the oxygenation, so we should get rid of this first. But let me just organize our thinking process. First, we need to make changes on the ventilator that will not affect minute ventilation. So this patient is put on 520 and the rate of 18, and his minute ventilation is 9 liters. And with this minute ventilation, his PCO2 is 37. Yes, we can tolerate a bit higher than 37, but I want to make the changes first that will not impact on the minute ventilation. And the first thing that you do, you are right, is just get rid of that inspiratory hold. So I'm going to go down all the way till I get rid of that inspiratory hold completely and see what happened. So it got better, right, Marwan? You can see, but it's not completely resolved. So what are you going to do? Faisal?
Yep.
Oh, sorry, I didn't know I was mute. I was answering actually.
Oh, okay, I'm sorry.
Yeah. So as I said that, so we can increase the flow rate, and so that will give us, will shorten the time we need for inspiration, the whole volume. So we then can shorten the inspiratory time even more.
Okay, so you're still concentrating on shortening the inspiratory time and taking this time, put it on expiration. So we can have more time for expiration. This is the right thinking. This is how you need to approach those patients. It's like, let me give the air as fast as I can. Okay. So you can see here, this is a volume control mode of ventilation. You can see the square wave of the flow. You can control the flow, right? And you're given the flow of 30 liters per minute. So what do you want to do? You want to increase the flow, right? What will happen if I increase the flow?
The peak pressure will increase, or the pressures will increase because we have increased flow with the same resistance, so the pressure will increase.
Okay, so I increase the flow for you to 50 liters per minute. Okay, and you can see how I just I'm going to freeze it for you so you can see the difference. And you can see how the peak inspiratory pressure is increased further. And why this happened? Because of the flow. And remember, with the equation of motion, the pressure required to get the air in is related to resistance multiplied by flow, plus volume divided by compliance. So here we have a higher flow, then we needed higher pressure. But this pressure is a central pressure, is not pressure at the level of the alveoli. We can tolerate higher than 30 centimeter of water of pressure. I usually do not like to see more than 50, 55 centimeter. Part of this pressure may transmit into periphery, and it may have some effect on the alveoli. Okay, so with this, when I increase the flow, Marwan, let me go to Faisal. And so what's next? Did that solve anything? What did we gain with this?
Yep. I think the inspiratory time stayed the same. Because we still have we are cycling by the time, I think.
Okay, excellent. So you're exactly right. You know, we are controlling the inspiratory time. So the cycling mechanism is the time here. So you increase the flow, you can deliver the 520 faster, but since we did not change the inspiratory time, all what we got is we got the plateau back. So in fact, we created the same situation like how we started. So in order to get rid of that, you need to go down on the inspiratory time. And let me go down to 0.62 and take a look on what happened here. So you can see that we delivered the volume faster. We're able to have more time towards expiration. However, we still have dynamic hyperinflation syndrome or auto beep here. You can see persistent, much better. We probably lower than by more than 60% compared to the baseline or how we started. However, we need to do more in order to get rid of this. What are you going to do? So notice by now, so far, what we did is we eliminated the plateau, we increased the flow, and we maintained the minute ventilation, the same thing. So far, we don't need to get blood gases. The CO2 is going to remain the same. We did not change the ratio of the dead space yet. We did not change the rate. The minute ventilation is the same. So there's no need for doing ABGs here. The CO2 is going to remain the same because you did not change the minute ventilation or you did not change the alveolar ventilation. So what's next?
I think next we'll try to decrease the respiratory rate, but at that time we will do another ABG to see what happens because we are decreasing the respiratory.
Excellent. So the first two maneuvers were directed towards maximizing the inspiratory flow or shortening the inspiratory time and prolonging the expiratory time. Okay. Once we say that, well, this is the maximum we can do, if you don't want to go higher than a flow of 50 liters per minute, well, at that time, the only way we can get rid of that auto beep is by decreasing the minute ventilation. And you can do this with two things. You can either decrease the tidal volume that you're inhaling. If you decrease the inspiratory volume, then there's less air to be exhaled. And we can probably improve the auto beep this way. Or you can decrease the rate. So let's go with the rate first and try to go down to 16 and see what happened. So now we're going to lose 1 liter out of minute ventilation. And that's almost 11–12%. So that means the CO2 is going to increase. You can see here how we improved it, but still not completely resolved. Now you did ABGs and the PCO2 is 44. The pH is 7.32. What are you going to do?
I think it's still good ABGs, but maybe we will increase the minute ventilation. But if we increasing the minute ventilation by increasing the tidal volume, we will have more peak pressure.
Well, why do you want to increase the minute ventilation for the patient? If you increase the minute ventilation, there are only two ways. You're going to go to higher tidal volume, but remember, how much tidal volume you want to give that patient? A patient with asthma, tidal volume should be between around 7 ml per kg. You did not ask about the weight of this patient. I can tell you the ideal body weight for this patient is 70 kilos, meaning that if you give him 7 ml or 8 ml, that should not be more than 560. Okay.
So we are
again,
ABG.
Yeah, the CO2 is 44, and you're doing everything possible to eliminate the auto beep. And this is the target. We want to eliminate auto beep. You may eventually say, well, I'm going to accept some auto beep. But if it gets to the point that, well, you did try your best to improve the inspiratory flow time for the patient, but the patient stays in auto beep, you would say that the next step is I want to decrease minute ventilation, not increase minute ventilation. You want to decrease minute ventilation further down, and this way you would accept what we call permissive hypercapnia. So you know that the CO2 is going to go up higher, but you're going to gain that you're going to empty the chest completely. So what I will do is I will go down to tidal volume of 500, let's just say, and rate of 14 and see what happens. So now we're going to have 500 by 14, that's 7 liters. We lost 2 liters out of our minute ventilation. and the CO2 will go up to 48, 49. But as I mentioned, anything up with a pH above 7.25 would be just acceptable. That's permissive hypercapnia. Okay, and this way you can see that we almost eliminated the dynamic hyperinflation. So let me stop here and see if anybody has any question. From the audience, you can raise your hand and I can try to clarify anything that was not clear. And I can give you the mic and you can ask the question. So it looks like it's very clear. I don't have any questions even in the chat section. Let me just go back.
So, Dr. Mazen, if we still like have a problem with the auto PEEP even after we did those measures, when would you apply external auto PEEP?
Well, we're coming to that.
Okay.
You know, this is the second half of it. But let me just tell you, if you apply an external PEEP, will you be able to improve the auto PEEP?
No.
Okay, so that actually is not going to improve your auto PEEP. You're going to live with it. And that's the next thing is actually if you did everything possible for the patient, you try to maximize the inspiratory flow time, you maximize the expiratory time for the patient, you accepted permissive hypercapnia, but any less minute ventilation is going to cause severe acidosis for the patient. Of course, you can decide to start the patient on bicarbonate infusion to overcome that respiratory acidosis. But sometimes you may say, well, I have to live with this auto PEEP. So if there is no way we can remove the auto PEEP for the patient, what will happen to the patient? Tell me, how is it going to impact patient's breathing?
How it's going to impact the patient's breathing? I think would it like, according to my understanding, it would improve the expiration, right? And probably like, I mean, it wouldn't relieve the auto PEEP. We are just gonna equalize it. But my thought process, it will improve at least the expiration while the patient having like, or going through this obstructive pattern of disease.
Okay. So let's try to explain. You see my screen, right?
Yes.
Okay. So on the left side here, there's you see end of expiration and inspiration. And this is a patient with no auto PEEP. How does this patient breathe? Or how does he trigger the ventilator? So we breathe with negative pressure ventilation, and we trigger the ventilator with a negative pressure. The negative pressure will create a gradient, and that gradient will generate a flow. That flow can be sensed by the ventilator, and we trigger the ventilator. So if there is no auto PEEP in the system, let's assume that the airway pressure is 0 and the alveolar pressure is 0. Okay. Of course, this is relative to the atmospheric pressure. So we're assuming that the atmospheric pressure is 0. Okay. So if the pleural pressure is 0 here, how would this patient inhale? He needs to generate a gradient. And that gradient is going to be between the atmospheric pressure or the airway pressure, which is here 0, and the alveolar pressure. In order to decrease the alveolar pressure, we need to decrease the pleural pressure. And let's say we decrease it by minus 5 centimeters of water. So that means that the alveolar pressure now is -4 or -5 centimeters of water. We created a gradient. With this gradient, we're able to trigger the ventilator, or we're able to inhale. If you set the trigger on the ventilator based on the pressure and you set it at -4 centimeters of water, the patient needs to generate that much pressure in order to trigger the ventilator. So now let's go to the right side here. This is a patient with auto beep. At end of expiration, the airway pressure is 0. The air goes in, does not come out completely. The pressure in the alveoli would increase. So let's assume that we have alveolar pressure or auto beep of 10 centimeters of water. And of course, when you have auto beep, part of this pressure is going to be transmitted to the pleura. And that's why I have a pleural pressure here of 3 compared to 0 without auto beep. So now think about it. How would this patient inhale, or how would he be able to trigger the ventilator? In this example here, I said a trigger at -4, it is -3. The patient needs to create a pressure of -3. So in this example here, in order to create that gradient between the 0 and the alveoli of -3, in order to trigger the ventilator, the patient needs to drop the pleural pressure from +3 to -13. So with the -13, 10 of them will overcome the auto beep of 10, and 3 centimeters will decrease the alveolar pressure to -3 centimeters. This way, we create a gradient. And we can trigger the ventilator. So you can see that if we have auto beep in the system, how is it going to impact the patient? He needs to exert more efforts in order to trigger the ventilator. And most of the time, actually, if he's not able to generate that much, he would be having ineffective triggers, and you can identify those on the ventilator scalars. So the patient needs to generate at least -13 centimeters of water inside the chest, which is negative pressure, in order to create a gradient and be able to trigger the ventilator. So how can we help this patient? Now it looks like it's very simple and easy solution for this. Well, let's just take a look on this. I put the patient who was on the right over there, the graphic that was on the right, I put it on the left here. So you can see this is end of expiration. Airway pressure 0, alveolar pressure is 10. With active inspiratory efforts, the patient has to generate -13 centimeters of water to create a gradient between the airway pressure and the alveolar pressure. So what we're going to do, we're going to add external PEEP. We'll add PEEP of 10 centimeters of water. So if we add PEEP of 10, now the airway pressure is up from 0 to 10 centimeters of water. That's the airway pressure. Okay. Now people argue how much of that pressure that we put externally is going to be added to the auto beep. Well, theoretically, it should not be adding anything. The pressure will equalize. So if we have auto beep of 10, it's going to remain the same, and the pressure will equalize in the airways and the alveoli at 10 centimeters of water. We still have the 3 centimeters of water, which are transmitted because of the auto beep. And now you can see here, all what the patient needs to do is, if we have airway pressure of 10, in order to create a gradient or decrease by 3 centimeters of water, all what we need to do is decrease the alveolar pressure to 7 centimeters of water. And we can do this by going down from +3 to -3. So the patient will only generate 6 centimeters of water negative inside the chest in order to trigger the ventilator, compared to the case before we added the PEEP. He needed to generate 16 centimeters of water. So this way, with adding PEEP, we did not change or did not alter, we did not improve the auto PEEP. However, we were able to improve or make it easier for the patient to inhale. So it would help you if you're not paralyzing the patient. If the patient is paralyzed, because when you have a severe airway obstruction, you may be needing to decrease all the resistance and compliance of the system. If you paralyze the patient because you don't want him to desynchronize with the ventilator, there's no reason for you to add external PEEP. You would add external PEEP only when there's inspiratory efforts and you want to make it easy for the patient to trigger the ventilator. Any question? So again, if you have any question, please raise your hand and I can give you the mic and you can ask the question. Or you can put it in the chat section. Okay, so let's get some examples. Marwan, can you please tell me what you see here?
Okay. This is liter per minute. Okay, I'm looking at the flow, like what's it called? This flow scalar or scalar. And I see here, okay, that what is it? Decaying curve. So maybe the patient is in pressure control, but he still could be on volume control.
Okay.
And then I see that the patient is taking volumes and has enough time for expiration, but the expiration, like the expiratory curve has like a notch in it, yeah, there is a couple of expiratory curves that have a notch, and then it looks like the patient maybe tried to inhale then or something. I don't know.
Okay. Excellent. So let's just try to analyze it more carefully. Okay, so let me start with the expiratory flow, because what we're talking about here is auto PEEP. So you can see that in this breath here, it goes to 0, right?
Yes. Mm-hmm.
In the second one, it doesn't go completely to 0.
Mm-hmm.
In the third one, it's even more obvious.
Mm-hmm.
So why did we have an auto PEEP here and we did not have it here?
The volumes that the patient took were larger.
Excellent. Excellent. So you can see here, larger tidal volume. The area under the curve is tidal volume. This is a flow over time. So the area under the curve is the tidal volume. So compare this tidal volume to this tidal volume, much larger. Okay, so with larger tidal volume, you need longer time to exhale. And this patient started the next breath before he exhaled all the way. And same thing happened here. You can see that this is happening again and again. But at the same time, as you mentioned, there are some activities here. You can see this activity. You can see that the patient is trying to inhale. So this is expiratory flow, right? When the patient tries to inhale, the flow would try to go up. So you can see that the flow went up to the 0 line, but was not enough to trigger the ventilator. And the reason being because of the auto beep. So at this area, when he inhaled, there's a pressure. There's a pressure. Of course, that pressure is in the circuit. And the patient needs to overcome that pressure. He needs to decrease the airway pressure, decrease the alveolar pressure to the level where he can generate a gradient and be able to trigger the ventilator. And he was not able to do that here. Similarly, it's the same thing actually happening here and another one here. So those are ineffective triggers. The patient is not able to generate enough pressure because he's doing this at the time where exhalation did not completely end. What about this one? Youssef?
So it's a pressure-controlled mode of ventilation given the square waveform and the pressure scalars. It's pressure triggered, and I can see that the main issue here, when we look at the flow scalars, is the again, like I feel like it's in the second wave, it's returning to zero almost.
Okay.
And then again, in the third one, it's returning to zero. I don't see any problem with the expiratory phase.
Excellent.
And the patient is trying to trigger the vent in the middle, but he's not able to.
Excellent. So you can see that the patient is able to trigger the ventilator here. So this is pressure over time. This is flow over time. And this is esophageal pressure. So it tells you how much efforts the patient is doing. And you can see that with good efforts here, he was able to trigger the ventilator. And similarly, this breath here is triggered, and he generated enough negative pressure to trigger the ventilator. This one, the same thing. And this one is the same thing. Now notice that he has other activities here. He has activity at this point here, and another one at this point. We have activity here and activity here. So those are happening in inspiration. So we're not going to concentrate on that at this point. I'm just going to talk about this one. Okay. So take a look on the esophageal pressure. It was dropped significantly, almost the same magnitude of the next breath. However, this did not trigger the ventilator. Why is that? So take a look again. This pressure is very similar.
Yeah, it's very similar
to this pressure. So he was able to trigger the ventilator here, but he did not trigger it here. See that?
Yes.
You see negative deflection. You see increase in the flow. Or the flow is pushed up.
The problem with that, if he triggers that, it might create desynchrony or double trigger.
Correct, but why he was not able to trigger? It's not double trigger. We're going to be talking about double trigger because he already finished the breath, and this is another breath. So this breath is happening when there's a still persistent flow. Take a look here.
Yes.
Okay. So if there's persistent flow, there's a pressure. So the alveolar pressure, actually you don't see it here. The alveolar pressure is going to go down like that. So this is what he needs to overcome.
Yes.
Okay. So this pressure is dynamic. It's going to go down gradually. What you see here on the ventilator is the trachea pressure. You're not seeing the alveolar pressure. Some of the ventilators will give you the alveolar pressure in a dotted line. And you will be able to estimate. And of course, there's no way you can measure the alveolar pressure. It's an estimate of what's happening at the alveoli. But this inspiratory effort here would need to overcome this pressure, which is still generated in the alveoli, and it's going down because the patient is continuing to exhale. So this is similar to auto-beep, but of course it's not auto-beep. This is just early trigger or early effort of the patient occurred before the patient exhaled completely and occurred at the time when there's alveolar pressure that needed to be overcome. If the patient had a bigger effort, let's change the color. If the patient had a bigger effort like this much, so at that time, this pressure is going to be able to generate a breath and trigger the ventilator. Because at that time, he would be able to overcome the alveolar pressure and be able to create a gradient and decrease the alveolar pressure to a level where he can trigger the ventilator. So I think that's all what I have for you today. So I can give you a few minutes to ask any question that you want. And people who are in the audience, you can unmute yourself or just raise your hand. I can give you the mic. Let me stop sharing. Can you explain the last point again? Okay. Dr. Sada is asking, let me share the screen again. So now we understand that in order to trigger the ventilator, we need to create a gradient. We need to decrease the pressure inside the alveoli to a level that is the same level as it is set on the ventilator. So let's assume that it is set at minus 3 centimeters of water. If we have auto beep, that means the end expiratory alveolar pressure is 10 centimeters of water here. In order to create a gradient, we need to decrease that pressure below the airway pressure. And in order to make it easy for the patient, we need to put external pressure here, which is equivalent to the alveolar pressure. This way, the patient does not need to decrease the pressure from 10 to minus 3. He will only need to decrease the pressure from 10 to plus 7. So that is only minus 3 centimeters of water. Coming down from plus 3 centimeters of water, that means the patient needs to generate only 6 centimeters of water compared to 16 centimeters of water if we did not have the external beep. Now, in the question here that we placed, when we identified the auto beep, we identified as persistent flow at end of expiration. If we have a persistent flow, that indicates that the alveolar pressure is elevated. And what I wanted you to understand is that the alveolar pressure will go down this is expiration. This is trachea pressure. The alveolar pressure will go down gradually till end of expiration. So that's what you see. The red line is what you see on the ventilator. The orange line is the alveolar pressure that you don't see. Okay. So if you cut expiration at any time, before that pressure goes down to zero, this is similar to auto beep. So the area here, this is similar to auto beep. If the patient needs to inhale here, this is inspiratory effort for the patient. During expiration, he could not trigger the ventilator despite the fact that he generated the same negative esophageal or intrathoracic pressure as the next breath. Why he was not able to do this? Because he needed to decrease the pressure from this point here. This is the alveolar pressure that the patient needs to overcome in order to trigger the ventilator. And that's why he was not able to trigger the ventilator despite the fact he has the same efforts. Is that clear, Sada? Okay, thank you. Any other question? You can put it in the Q&A in the chat section, or you can just raise your hand and unmute. I can unmute you. If no other questions, tomorrow we'll be talking about protective lung strategy. It's going to be at the same time at 8:30 Chicago time or 9:30 New York time. Thank you very much for your attendance and see you tomorrow.